This one.
Recording button here. Hello, everybody. My name is Lydia Fuqua. I will be your moderator this morning. Thank you so much for joining us for More Than Dependency, the Neurobiology of Addiction. I want to start out with a couple of housekeeping reminders before I turn it over to our presenter. This session is being recorded and it's going to be available on the conference platform 1 hour after the session ends. It looks like when we join the session, we're actually all unmuted, so please take a moment to mute yourself to prevent any of that lovely, awful feedback that we sometimes get when multiple people are unmuted. We would appreciate it, unless Eric asks otherwise in terms of feedback from the group. Feel free to drop your questions in the chat. I'll be keeping an eye on the chat so we can make sure that Eric gets your questions answered. And be sure to join sessions live today because we will be doing a prize drawing from attendance within each session. So very exciting opportunity there. The conference is also offering free continuing education credits. So for more information on that, you want to visit the continuing education page on the platform. And with that, I am very excited to introduce Eric Thomason, who is the Director of Behavioral Health and Addiction Treatment Services at the Community Health Center of Southeast Kansas. Eric, thank you so much for being with us today. And with that, I'll turn it over to you.
Oh, thank you all very much for having me. So I will try to make this as eventful and memorable as I can. The telehealth platform or the virtual platform can take away from it a little bit, but please, everyone, ask questions as I'm moving through the slides. My goal is to try to get this presentation done in about 40 minutes to leave 15 to 20 minutes for questions, comments, anything else like that. I was warning Lydia, I either go short or long, so we'll aim for 40 minutes and see what happens. So in addition to being Director of Behavioral Health Services, I am also a psychiatric nurse practitioner. I manage depression, anxiety, schizophrenia, bipolar disorder, primarily using medications. I also treat opioid use disorder, alcohol use disorder with medication-assisted treatment. The overview for today is addiction, of course, is a multifactorial disease. My goal is to hopefully communicate some of the overlay between what psychiatric illness and the effects of addiction and the effects of substances can have on the same neurotransmitters that are responsible for some of the difficulty we face with substance use disorders. So to hop in, everybody, I'd like to tell you a story about Joanne Doe. Obviously, that's not her real name. She is a divorced Caucasian female in her mid-30s. She came to see me several years ago after being released from prison. She was being held for nonviolent drug offenses. She began struggling with addictions in her early teens. She's a survivor of sexual assault as a child, struggled with mental health issues throughout most of her life, had been incarcerated, but had never been in inpatient substance abuse treatment. I know that doesn't come to a surprise to a lot of you. I saw her after getting released from Department of Corrections. I treated her depression, diagnosed with major depressive disorder and stimulant use disorder. This woman had overcame a variety of issues in her life, had displayed resiliency in so many different areas, and was re-engaging back with her 3 children. She was working, she was living independently. I saw her for 4 sessions. She was better. She relapsed on methamphetamine and subsequently committed suicide. From that moment, I guess it's been a personal journey to figure out why. And I don't know if we're any closer today than we were several years ago, but my hope is that this presentation will give you an opportunity to think about some of the treatment that our patients receive, and keep in mind that these patients are siblings, children, parents, grandparents, and they all deserve equitable treatment. So hopping into it, maybe, we think about addiction as a multifactorial illness, a variety of reasons that can contribute to substance dependency or substance use disorders. We know that there's genetic predispositions. We know that if direct family members, parents, siblings, suffer from substance use disorders, there's a higher probability that your patient's going to suffer from a substance use disorder. We know that folks who experience difficult things in their life are at a higher risk for developing a substance use disorder. We know those that struggle with a mental health issue are at a higher risk for developing a substance use disorder. We also know that disease state can contribute to substance use. So someone who is depressed, or someone who may be anxious, or someone who may be manic or psychotic are at a higher risk for substance use disorders. When we specifically break down some of the demographic, we know, or evidence will tell us, that currently those with a mental health diagnosis are twice as likely as the general population to suffer from a substance use disorder. We know patients with severe mental illness like bipolar disorder and schizophrenia are 4 times as likely to struggle with a substance use disorder. And greater than 60% of those with a stimulant use disorder relapse within 1 year of treatment. We know that 60% of patients struggling with a opioid use disorder are going to relapse within 12 months of treatment. The scary thing that I didn't include in this, because I want to convey hope, is that there are some studies out there that suggest relapse rates for stimulant and opioid use disorder are upwards of 80 to 90% post-release from treatment. The major caveat to that is that for the treatment of opioid use disorder, medication-assisted treatment that we'll talk a little bit about later has been shown to reduce overall risk of relapse. Approaching this topic has been a challenge for me, because I know that there's some in this room that are not medically trained. I know that there are some in this room that don't necessarily work in addiction treatment, but maybe representatives of our criminal justice colleagues, or administrative colleagues, and so on and so forth. And so the next few slides are going to focus kind of on a crash course of neuroanatomy and the effect of neurotransmitters, and how they play a significant role in not only mood, anxiety, mental health, but also within the addiction realm. And I also will apologize. The front slide was about the best looking slide in this deck. And so I wanted something clean, easy for me to follow, because I can get easily distracted. And so the rest of the slides are going to look like this, so bear with me. And Lydia is going to be checking for any questions that come up, so she will interrupt me. Organizing the chat box in 2 windows is a little much for my technological know-how. So this slide is pretty gosh darn important when we think about overall functionality of our brain, right? And so when I talk with a group of non-addiction trained folks, or I'm talking with my board of directors or anything else like that, I usually start with a question. And I say, what makes hypertension a disease? And they'll go on and they'll tell me about, well, high blood pressure can lead to all these challenges and difficulties, and et cetera, et cetera. And then so I posit the next question. I say, well, what about addiction, right? And we run into the same issues with addiction. So type 1 diabetes, our pancreas is betraying us. The organ that's responsible for determining whether or not our behavior is appropriate or our thought process is appropriate is our brain. And when we think about addiction and mental illness, that is the organ that betrays us. And so as we look at this outline of the brain, should be on y'all's left, we see the prefrontal cortex, which is the new and improved area of our brain, if you think from an evolutionary perspective. That's where we see a lot of our higher executive functioning. That's where we are able to inhibit some of the impulses that come through. That's also where we see dysfunction with schizophrenia, dysfunction with bipolar mania, lack of blood flow, lack of neurotransmission with some of our depression, most notably the mesocortical area of the brain. Y'all aren't going to be quizzed on this, but we will reference these areas later. The nucleus accumbens, that's the money maker in addiction, right? That's the reward center. That is the thing that betrays us. The ventral tegmental area is highly saturated with this thing called dopamine. That's our feel-good molecule. That's the piece that rewards our behavior. The nucleus accumbens in the ventral tegmental area, VTA, references the old area of our brain. Evolutionists believe that monkeys have a very similar structure of this. It focuses on the pleasure principle. If it feels good, do it. Don't worry about the consequences. And then we do it again and again and again. The mesolimbic area of the brain, a little bit shorter, but that is where you can see an outreach from the old area of our brain to the new area, the inhibitory area. And the nucleus accumbens sits right on that tract. And that's important because the mesolimbic pathway of the brain is one of the 5 major dopaminergic pathways that exists for humans. And so when we theorize, and I use the word theorize because a lot of this we have not definitively proven, when we theorize the mechanism of action of drugs, when we theorize the mechanism of action of stimulants or opiates or prescription medications, this is primarily the area in which we focus our attention, which opioids has kind of opened the door to some other potentials. Shifting to the right, we focus in on the nucleus accumbens. This area has nicotininergic receptors, glutamate receptors, which is an excitatory molecule that also can reinforce reward, alcohol receptors, and then of course GABA receptors, that is a calming molecule. And so when we think about the effects of someone who's drinking, and we call that a depressant, that is why we call it a depressant. When we think about opioids, opioids impact GABAergic neurons. Ketamine impacts GABA. And so as we're moving forward, think about this slide, think about the way that this looks, because this is a very important piece to help understand neurotransmission and why we are the way that we are. When we look at neurotransmitters, there are very many different types. This is a very simplified approach to neurotransmitters, specifically dopamine. We have targeted primarily 4 different types of dopamine or subtypes of dopamine that carry a very significant and different impact on our bodies. So please, guys, this is a superficial approach to understanding these neurotransmitters. Happy to speak more at length, or you guys can call me. I'll have my cell phone information on the end of the slide. So dopamine, of course, is largely associated with reward reinforcement. It also serves as a mood stimulating chemical. So it helps lift our mood. In excess, it can create panic and anxiety. Opioid peptides are specific opioid receptor types. We look at mu, kappa, delta. We don't know a whole lot about delta currently, but we believe that mu opioid receptors, when we increase neurotransmission, it increases euphoria, it increases the impact, it increases reward, which is different and outside of our dopamine pathway, which is why some interventions work for opioid use disorder, but they don't work as well for stimulant use disorder. Norepinephrine is believed to play a role in executive functioning and regulation of cognition, motivation, and intellect. Norepinephrine lives at that very front area of our brain. And so that's why some of our antidepressants do a better job of stimulating folks and improving their cognitions, most notably viroxetine. Serotonin is associated with reward reinforcement. It's also associated with improved mood and management of anxiety. And then this Y-aminobutyric acid, I'm going to call it GABA from here forward, modulates NMDA, thus improving cognition, mood, and can contribute to emotional stability. And so when y'all think about NMDA, I want you to think about all the data that you're reading about ketamine. We believe that treatment refractory depression can be improved by direct modulation of NMDA, bypassing the reliance on GABA and attacking that molecule in itself. For the remainder of this presentation, we will not hear much more about NMDA, but I'll share some information with you guys. So when we look at the addiction cycle, man, I love this. Sadly, I did not see this data until I was preparing for, or this outline, until I was preparing for this presentation. It's one of the reasons why I do these things, because it forces me to learn. So when we think about the addiction cycle, we see the binging and intoxication, the withdrawal and negative effect after intoxication, and then the cravings or the anticipatory reward that comes along with use. And here's the beautiful thing about this. This was published on an obesity website. So we see neuroanatomical changes in our patients without using neurotransmitting drugs. So a patient who struggles with obesity, gambling, sex, they all fall within this cycle. And so we're going to talk a little bit more about what happens to our neurotransmitters within this cycle. And please, 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 please keep in mind, this is without substances. We just make it even worse when we use. So neurocircuitry of addiction, when thinking back, and this is the very superficial part of this, guys, the primary point of the next two slides is I want you to see what the overlay between depression and the neurocircuitry of addiction, or think about that addiction cycle, okay? When we're living in the binge intoxication area of that addictive cycle, our dopamine goes up. Theoretically, it's supposed to make us feel better. It's supposed to give us euphoria. It's supposed to reward that behavior. Serotonin increases, our antidepressant molecule increases. And then, of course, when we think about GABA, we see an increase of GABA as well, which is a little counterintuitive to what you would think somebody high on meth. They don't appear very calm most of the time, but there's a reason for that. And remember, this is not on substances. As they progress to the withdrawal or the negative affect that comes along after their intoxication, you see a decrease in dopamine in both the mesolimbic and mesocortical areas of the brain. So the reward center of the brain, the mesolimbic tract, decrease the dopamine, which perpetuates the craving. We see an increase in norepinephrine, and here's what's really interesting about this. This is the major contradiction between the next slide of what I'm getting ready to show you. An increase of norepinephrine in depression is a good thing because we assume that there is such a deficiency. When we do it with a non-depressed brain, we increase it excessively, which contributes to excessive release of hormones and chemicals from your kidneys, your adrenal glands, which perpetuates panic, anxiety, fear. In the withdrawal and negative affective phase, we see a decrease in serotonin, right? So without a substance, an addicted brain in the addicted cycle appears clinically depressed. Preoccupation and anticipation. When you know the high's coming, we think relief's coming. This is also the same area where we can instill hope. Giving hope to a patient also has this effect. So we see an increase of dopamine in the mesolimbic area of the brain. We see an increase in dopamine in the mesocortical area of the brain, higher executive functioning, the inhibitory factors. And then we also see an increase of serotonin, which is supposed to impact mood. So next slide. These are the leading theories, the monoamine theory of depression, if you will, for chronic mood disorders and schizophrenia. So someone who has bipolar disorder and they're depressed, deficiency of dopamine in the mesolimbic, mesocortical area of the brain, see an increase in GABA. Bipolar mania, we see an increase in dopamine. These are the patients that are not sleeping, maybe psychotic, maybe not thinking clearly. Someone, if you have more working history with people who are acutely high on meth, someone who's on meth. Schizophrenia is unique because you see an increase of dopamine in the mesolimbic area of the brain, where it creates the hallucinations, delusions, irritability, anger. And you see a decrease in the mesocortical area of the brain. This is where someone may be neglecting their hygiene, or they're not socially interacting any longer. And that's what makes schizophrenia so dang hard to treat, and why we see some of the highest rates of substance abuse and schizophrenia is because they have such a deficiency of dopamine. They want to feel better emotionally or from a mood perspective. So they increase their dopamine with meth or cigarettes or whatever else. And it makes their hallucinations potentially worse. And then, of course, with major depressive disorder, we see a deficiency or a decrease in mesolimbic, mesocortical, norepinephrine, and serotonin. So my hope is that you guys are starting to pick up some of my concerns when we treat these patients. A lot of you know this, but for those who don't, I thought it was important to include. The DSM-5, our diagnostic manual, outlines psychological components of disease. It also looks at psychosocial adversity or negative effects in your psychosocial life as part of the diagnostic criteria as well. So legal implications for a DUI, separation after a marriage. All of those things we can use in the DSM-5 to determine what degree of psychosocial impairment their use has. And if they've got some of the physiological, like dependency, tolerance, and they have some of the psychosocial, like difficulty at work, difficulty at school, marriage, spirituality, then they meet criteria for a use disorder. So I get a question a lot from the students that I take on, or the students I teach. They say, Eric, how do we know it's a problem? If I go and drink 3 beers on a Saturday night, how do I know I don't have alcohol use disorder? And my question is, to what degree are you impaired from a psychosocial situation? Or are we going from 3 beers to 12 beers to try to get the similar effect? Do we have tolerance? One of the statements I found as I was going through neuroanatomy refresher for this, points of consideration for the addicted patient. Once the brain is addicted, we are no longer fighting the fight against meth. We are fighting the fight against the anticipation of reward. That's the challenge with addiction, is we are fighting not what really happens when they use. We're fighting the dopamine reward release prior to use, because it's usually not as good as it was or you thought it was going to be. A phenomenon called conditioned stimuli starts to happen. And this is where our patients talk about, I'm addicted to the needle. It's the preparation, it's the dopamine release as they are filling the syringe that is giving them the reward. Once again, we're no longer fighting the drug. We are fighting the process to get the drug. And then finally, reward conditioning. This is where we see that imbalance or that conflict between anticipatory versus actual reward. And I put in anxiety in there by mistake. I apologize. There should be anticipatory reward. I talk about anticipatory anxiety with a lot of my patients, similarly to this. The anticipation is better than the actual effect. So the challenge, we have to change that mindset. How do we do it? That's not what this is about. So talking about stimulants on our brain, okay? So methamphetamine directly increases extracellular serotonin, norepinephrine, and dopamine, right? So it creates antidepressant environment. It can promote euphoria, promote wakefulness, suppress appetite for some of those folks, because the reward center is so saturated with dopamine that they're not experiencing hunger, because hunger is also driven from the reward center. Overactivation of dopamine may lead to a variety of things, and this is typically when we see our patients, right? Unstable mood or emotions, worsening symptoms of anxiety or panic, hallucinations, delusions, anorexia, or cardiovascular events. So breaking that down, unstable mood or emotions, too much dopamine, mesolimbic area of the brain. Worsening symptoms of anxiety or panic, norepinephrine, prefrontal cortex, front of the brain. Hallucinations, delusions, paranoid ideation, mesolimbic area of the brain. Anorexia, mesolimbic area of the brain, nucleus accumbens, reward center. Cardiovascular events are norepinephrine driven primarily through the adrenal glands. Impact of opioid use. What's interesting about this is we have focused the last 20 years of science in or research in the science of understanding monoamines, norepinephrine, dopamine, serotonin. And now we're starting to transition to glutamate and GABA, right? And opioids live in a different world. They do have indirect effect on all of those, but the primary mechanism of action lives in the opioid reward system. And so what we will see is that if we increase neurotransmission at mu opioid receptor sites, we see anti-anxiety effect, antidepressant effects, and pain management. When we reduce neurotransmission at kappa opioid sites, we can see anti-anxiety effects, antidepressant effects, and some pain management. And it's a mixed jury on the impact of delta opioid receptors, so I won't get a ton into that. The key thing to note here is this is acute activation. Long-term opioid use has been shown over and over and over again to worsen symptoms of depression. We're not entirely sure why that happens, but we do see a reduction in monoamines or brain chemicals, similar to what we see with our depressed patients. Chronic and excessive opioid use may lead to, of course, respiratory suppression, tolerance, depressed or flattened mood, and death. But make no mistake, in a previous life, I worked at a emergency trauma center, and I had people die from methamphetamine use as well. They go into a lethal heart rhythm, and we can't get them out of it. So current evidence and interventions for stimulant use disorder, guys, here's the not so fun news, right? There is limited support for pharmacological interventions, or basically, there is not a lot of evidence out there that medicines make this better. And it's incredibly unfortunate because it's a whole lot easier to take a pill every day than it is to show up and work on yourself, work on cognitive distortions, work on an addicted mindset. And so there is expanding research going on currently that's looking at the utilization of a variety of medicines. But as of now, meta-analysis published earlier this year, very limited support, including controlled release stimulants. Serotonin-based antidepressant stimulants and buprenorphine, which is an opioid, has had limited success in the management of stimulant use disorder. Locally, there was this idea that went around that said if we can prescribe controlled release stimulants, we can use it similarly to how we use buprenorphine or Suboxone to treat opioid use disorder. What we have found is that's not accurate, and that's been repeated in literature multiple times now. The most effective, and this is sad as well, the most effective pharmacotherapy is a combination of bupropion, which works on norepinephrine and dopamine. It increases norepinephrine and dopamine, and the extended release naltrexone, which reduces mu opioid activity and increases kappa activity in the reward center of the brain, has been shown to outperform a placebo for relapse prevention, treatment participation, and methamphetamine use reduction. And so in the arm that received it, you're still looking at just barely 1 out of 10, or a little bit better than 1 out of 10. So 11.4% at 12 weeks compared to 1.8 the placebo. So in this trial, sobriety at 12 weeks is 2%. That's the battle, and that's the point of this presentation, is to not give you guys the answer, because I don't have it. To help you guys think about what the answers could be, advocate with your superiors, advocate with state legislature to make those changes. I just want to reinforce there is no FDA approved medication approved for medication-assisted treatment. Contingency management therapy, for folks who don't know what that is, it's basically a reward system, and I'm oversimplifying, so I apologize, don't mean to offend anybody. It's a reward system for participation in treatment. Maybe they get gas vouchers, or they get food subsidy, or they get a variety of other things that will help improve their psychosocial determinants. And they get that for participating. And then, of course, cognitive behavioral therapy is second in regards to efficacy. Current evidence and interventions for opioid use disorders. Medication-assisted treatment, that should be new to no one. This has been a very hot topic over the last 10 to 15 years. It's basically using opioids to treat an opioid problem. That's an oversimplification, but I always like to say that to get people to argue with me about its efficacy. Utilization of medication-assisted treatment has reduced emergency room visits and hospitalization admissions. And if you get an opportunity, pull this reference, guys, and read it, because it is absolutely incredible. I think this took place in either New York City or Boston. Different challenges to rural Kansas, same addiction mindset. I use this slide to present at our Sheriff's Association for a program that we helped launch in one of our county jails here in Southeast Kansas. And it was a medication-assisted treatment program. That was the primary intervention. And we do a little bit of counseling. We do a little bit of social services. But primarily due to turnover inside the jail, we do a lot of, I will evaluate the patient, determine if they're appropriate for treatment, and we will prescribe a lot of Vivitrol or naltrexone. And so I wanted to take a moment here to talk about what that actually is. I assume there's someone else presenting on it, but I really want to reinforce my perspective and how this works. So I drew this up myself, as you can tell from my slide deck. Creativity and being blessed as an artist was not something that was given to me. And so when we think about medication-assisted treatment, we primarily break it down by methadone, Suboxone, or buprenorphine is the active drug, and then Vivitrol. And so methadone functions very similarly to oxycodone, hydrocodone, and heroin. They're what we call a full agonist. And so if you can imagine taking that little heroin block, sliding it over, it perfectly sits on the opioid receptor and it maximizes neurotransmission. So it drastically increases neurotransmission at mu opioid receptor sites. This is where we see our greatest risk for overdose, constipation, death, dependency, etc. Buprenorphine, naloxone, buprenorphine is an opioid as well. But as you can see, it sits kind of sideways on the opioid receptor, doesn't fully align up, but it does allow for some neurotransmission of mu opioid receptor sites. So when we think about these patients, we think about patients who are still receiving some of the benefit, the increase of dopamine, the increase of serotonin associated with taking buprenorphine. When we use buprenorphine, a thing to know about it is it binds incredibly tight, y'all. Very tight, very hard to push that drug off of the receptor. So play a game with me, slide the buprenorphine over. So now it's attached to the opioid pathway. Now try putting heroin on that. You can't. The buprenorphine is blocking the opioid receptor. So heroin won't work, oxycodone won't work, hydrocodone won't work, fentanyl will. That's why it still kills people. I tell this to every patient that I do an induction with, or the nurse Amy I work with does an induction with. Suboxone, the purpose of Suboxone is to buy you time to where you can successfully withdraw. And I want to say that again. Buy the patient time to where they can successfully withdraw from their drug. Because if you're on an opiate, you're going to withdraw. That's the cold, hard facts of all of this. We have a requirement that you participate in substance abuse counseling, or you don't get a prescription. Doesn't have to be with us, can be with anybody. Our partners at Crawford County Mental Health, doesn't matter. You have to be with us. So that makes it hard. People miss appointments. People divert. People stop showing up. They run out of Suboxone, they withdraw. So the goal of Suboxone is to buy time, to let them get their job in line, let them repair relationships, let them get stable housing, stable food, income. So then they have the psychosocial determinants to help support a successful withdrawal. And then lastly, if you look at naltrexone, one last thing about buprenorphine. Suboxone is buprenorphine plus naloxone. And so the beauty of that is naloxone is not effective or does not activate when you take it orally, right? So naloxone is the reversal agent for opioids, Narcan. When you inject Suboxone, you melt it down or you break it down and you inject it, then naloxone becomes the active ingredient. So if a patient attempts to abuse and inject Suboxone, they're going to put themselves into withdrawal. And it happens. And I and the nursing crew that I work with, they receive these phone calls, and it's very awkward for the patient. But it gives us an opportunity to provide them better support because clearly they need it. Naltrexone is a drug that works on opioid receptor sites. Think about sliding that naltrexone over to the opioid pathway, fully blocks it. So they don't get effect except fentanyl, because fentanyl binds so incredibly tight. Also, because it does decrease kappa receptors, and if you think back to our slides earlier, decreasing kappa has antidepressant effects, creates anti-craving effects. Decreasing kappa can help prevent withdrawal. That's how naltrexone works. That's why it's FDA approved for the treatment of alcohol use disorder as well. Naltrexone extended release. The beauty of it is it's once a month. So when we have a patient who's struggling with impulse control issues on substances, we don't have to worry about them taking the medicine every day. We just have to get their butts into my clinic one time a month. And then they don't have the option to not take their anti-use drugs in my office. So everyone, I understand that this was probably a whole lot of gibberish for a lot of you. But my hope is, and as we think about this in conclusion, that the cycle of addiction creates a depressed brain, or it creates a brain that looks an awful lot like depression. Now, genotype, or what genes or neurotransmitters, don't always appropriately predict phenotype or what the outward expression of it is. But when we are taking patients off of these substances, or helping them get off of these substances, the cold hard truth is that we make some of them worse. And so when we think about Joanne, my patient, Joanne Doe, I can't help but think about that. When she relapsed and she was hell-bent determined to get sober again, what were her brain chemicals doing? I don't know. What I do know is a mother of, or 3 kids are going to grow up without knowing their mom, which sucks. And so the point of this is, if your facility or if your practice does not have access to psychiatry, advocate for it. I know we're hard to find, but advocate for it, because these are chemically induced elevations in neurotransmitters, and they at times will need to be chemically balanced for the foreseeable future. So the three questions that I want you all to think about, I don't necessarily need answers to them. You're more than welcome to reach out to me. Is which came first? If addiction can create a depressed brain, was it the 15-year-old smoking pot that induced neurotransmitters to become depressed? And now they come to us despite being sober and they're depressed again. Or was it the psychiatric illness, or is it both? And how many times are you asking yourself that when we visit with the patient? Are we inducing, and I wanted to use the word crisis like this on purpose, be dramatic, right? Get you all's attention. Are we inducing a mental health crisis when we take patients off of illicit drugs? Are we inducing a mental health crisis when we are working through the cycle of addiction? I don't have the answer to this. Part of me worries we are, especially if we don't have access to preventative therapies like SSRIs, SNRIs. And I want to clarify one statement I made earlier. There has been no evidence to show that SSRIs or SNRIs are effective in preventing methamphetamine relapse. However, numerous studies show SNRIs and SSRIs are effective for mood stability post-detox. Those are two different things. Are we managing the mood or are we preventing relapse? Two different things. Keep that in mind. Antidepressants have been shown to be effective in managing mood. And then finally, and I guess this is for you in your practice in your clinic, does a lack of behavioral health in psychiatry integration impact treatment outcomes and remission? The data that I reviewed exponentially say yes. I've got 7 psychiatry providers that I am incredibly lucky to have at Community Health Center. I know y'all aren't as lucky to have that. So I strongly encourage, advocate for it, because I do believe there's a time and place for non-pharmacological interventions. And guys, the therapy is what's going to heal our patients. But my concern is, can we get them to you? Can we get them into therapy stable-ish, like any addiction patient? Guys, I want to say thank you for giving me this platform to talk. I really enjoy speaking in person and answering questions as I go. The only thing I want to leave you on is tell their story. We all have Joannes. We have Johns. We have patients that we remember, but some of our administrators never will, because they weren't there taking care of them. They don't think about the 3 family members. And we have some administrators who do a really good job of doing that too. So not to stigmatize them, but tell their story. Tell their story to our legislators, our folks in criminal justice. Tell the story of how difficult it is to have your correctional staff try to manage depression, anxiety, schizophrenia, substance withdrawal. Tell those stories. That's the only way that we are going to change this. So please do it. This is my contact information. Guys, send me emails. You're more than welcome to text and call. If there's anything that I can do to help out, please let me know. If you guys want to talk over, want more information on neurotransmitters and the impact of neurotransmitters on mood and substance use and vice versa, please don't hesitate to reach out. Looks like we've got about 14 minutes, so I did pretty good. I'm happy to answer any questions that y'all might have.
Awesome. Thank you so much, Eric. We did have several questions come through the chat, but you were on a roll, so I kept track of them for you. So the first question that we received was, what are your thoughts on marijuana treating depression and anxiety?
So my thoughts are, and if it hasn't been published in the last few months, I'm unaware of any randomized controlled trials, medical grade trials, that show that marijuana is effective for generalized anxiety and depression. And I do my absolute best to try to stay in line with what's evidence-based for practice. There is some mixed data out there that looks at marijuana use for panic disorder and acute symptoms. However, we have to worry about rebound anxiety. Same reason why we don't want to be using a bunch of benzos for chronic anxiety. It's a long-term problem. We need to address it in a different way than a short-term solution.
Thank you. The next question we received was, since meth use provides an antidepressant effect, should antidepressant medications become a form of MAT to treat meth addiction?
Yeah, and so that might have come in before I made that difference. Antidepressants, when we look at medication-assisted treatment, and what's FDA approved is treatment outcomes for that looks at relapse prevention and reduction of use. So antidepressants have not been shown to reduce use of methamphetamine, but they have been shown to stabilize mood. The exception to that, of course, is the Wellbutrin. And so if you think about SSRIs like Prozac, Zoloft, Celexa, SNRIs like Effexor, Cymbalta, you look at drugs that pretty much bypass dopamine. And dopamine is the major neurotransmitter that's associated with methamphetamine. So it's great to help stabilize mood, but currently the best evidence we have is a combination of naltrexone and Wellbutrin, or bupropion.
Great, thank you. The next question that we received was, do you work with any organizations who utilize psychological therapies if medication doesn't improve the addictive behavior?
Yes, absolutely. So where I currently work, we've got 3 addictions counselors that I work very closely with. We've got 2 registered nurses. We have a peer support specialist and a social worker who helps focus on the social determinants of healthcare for these folks. We also have we probably employ about 25 to 30 therapists between master's prepared social workers and then PhD and PsyD trained psychologists. Now, also keep in mind, I know that sounds like an incredible amount of staff, and I'm very grateful for the amount of staff we have. We also serve like 9 or 10 counties in southeastern Kansas, so we're spread pretty thin. I also work closely with community mental health centers and their team. We are very grateful for Crawford County Mental Health down here in Crawford County, Kansas. They have an inpatient addiction treatment program, and they've got great counselors that also work with some of our medication-assisted treatment folks. So we just coordinate between facilities.
Awesome. Thank you, Eric. We did have a question about kratom and what your thoughts are on kratom.
Yeah, so a really good question and a thorn in my side. Kratom functions as a mu opioid agonist. So it increases mu neurotransmission associated with its use. And so we run the same risk of withdrawal phenomena and side effects of respiratory suppression. There has been an increased incidence of seizures, and we're not entirely sure why. Someone in the audience may know that. But we have seen an increased risk of seizures with high doses of kratom, but it is a challenge. I prefer not to use it. If I'm going to detox a patient, I'm going to follow a lot of the FDA guidelines and use medications consistent with that, which kratom is not. But I know you always hear anecdotal stories about people getting off of opioids with kratom. It just makes me anxious.
Thank you. Thank you. Couple other questions here related to MAT for meth use. Some folks asked about both naltrexone and Wellbutrin, as well as doxepin for stimulant use disorders. Wanted to get your thoughts on those.
I will be completely honest. I haven't read any research on the use of doxepin, but I absolutely will. Doxepin is an old tricyclic antidepressant. And so tricyclic antidepressants are very potent, and they do a really good job hitting a variety of neurotransmitters, including norepinephrine. And without getting too nerdy on the group, norepinephrine does have some indirect effect on dopamine. And so theoretically, I mean, I could see the potential of using doxepin for some side effect management as well, like anxiety, depression associated with relapse. It also binds very tightly at histaminergic receptors. and can cause sedation. So to help those people get to sleep. I personally haven't used doxepin, and I'm not aware of a ton of research on it. Naltrexone and Wellbutrin or bupropion, absolutely. That references the study that we looked at where we saw, I think it was 14% or 12 to 14% of folks had better control of their stimulant use disorder as compared to placebo. And they were on a combination. This is important, guys. It was a combination of bupropion or Wellbutrin plus the injection of naltrexone. The problem with naltrexone is when you take the pill, the bioavailability or how much that's actually absorbed is less. And so, and you have to worry about daily compliance issues as compared to the injection. But yeah, naltrexone, the way that it acts on our reward center, absolutely can be helpful for addiction.
Thank you. This is kind of a question related to that somewhat. So someone mentioned that naltrexone is certainly the most expensive treatment, and wondering how to make it more accessible or how to advocate for access to aid in patient recovery.
Oh my gosh, beautiful question. Amy, the nurse I work with, she's on the phone with the representatives, the pharmaceutical representatives who distribute Vivitrol daily or at least weekly, are requesting samples, which they do give. They don't like to. Patient assistance programs for people who qualify for income reduction. One of the points too is there is Beacon grant funding available that will help offset some of that cost of Vivitrol. But the rest of it, I really think looks at advocating to our legislators and advocating to the people who are in power that, hey, we need better access to this, whether it be private insurance groups. I know CanCare and I treat some folks from Missouri, they cover it. And so, and not to make this a political thing, but Medicaid expansion as well. If we have more people who have Medicaid, then they have better access to these medicines. So.
Thank you. We have just a couple more questions that came through in the chat. This one says, you might have mentioned this, but what type of OP therapies can you provide for patients in your MAT program, and is this required? Yeah, so there is a requirement if you're going to receive Suboxone or buprenorphine, which is the active opioid, that you participate in therapy. We do have some folks that are receiving our Vivitrol injection that are not consistently seeing a therapist, but we do have our peer support specialist that checks in. As far as modalities go, we cognitive behavioral therapy, we use some of the matrix models in one of our curriculums. We do individual and group therapies, primarily at one of our clinic sites, not the rest due to staffing difficulties, but yeah. Great. And just a couple more questions here. Yeah. How do you feel about clinical ketamine treatment for depression? Oh my gosh, I know this sounds a little wild, but why not? Right. So a lot of people don't know this, but there is a very strict criteria and policy for prescribing ketamine for the treatment of depression. And so, especially if you're trying to use the branded drug S-ketamine or Spravato, it requires hours of supervision on the clinic with each administration. But the truth of the matter is, due to practice restrictions and payment resources, we don't have a ton of options for treatment refractory depression. S-ketamine has been shown to be one of them. What's really interesting and kind of scary, without getting too far off topic, there was a study, it was a small study that was published out of Stanford University that looked at patients who were non-responding or minimally responding to antidepressants. And the psychiatrist down there had this idea that, man, ketamine works on opioid receptors. That's one of the things that it does. Everybody falls in love with ketamine for its antagonism of the NMDA, but nobody thinks about the opioid reward system. So he did something interesting. He gave ketamine to people and they got better. And then a different group of people, he gave ketamine, but also gave them naltrexone, which blocked the effects of opioids, or the opioid receptor that comes, or the opioid binding that comes along with ketamine. They didn't get better. And so there's actually drugs down the pipeline that is utilizing buprenorphine, which is a partial agonist at mu opioid receptors,
as an antidepressant therapy. And you're like, man, that sounds cool, right? But then you're like, holy crap, dependency, addiction. What are the unintended consequences of that? I think ketamine's the low-hanging fruit. We've been studying effects of ketamine since 1990s, 1980s. And there is a very strict requirement that goes along with it. I'm more apprehensive about the potential of opioids, which, by the way, that drug was not approved by the FDA. It was being manufactured by a group called Synovian.
Wonderful, thank you. The last question that we have in the chat is, could you give a quick overview of how you approach treating addiction in patients with ADHD, or things we should keep in mind while working with those folks?
Yeah, oh my goodness, this is going to be a loaded question, and I'm my opinion may differ than a lot of others. However, one of the things I promise to do when I treat patients is not harm them. And withholding evidence-based treatment is harming them. It does not matter. Look at the research. Stimulants, dopamine agonists, methylphenidate, amphetamine, both of them have been shown to be the most effective treatment of ADHD. Strattera is close, but it's not. It's not the same. And so we also know that untreated ADHD and the chronic impulsivity that can come along with that increases the risk for substance use. And so my approach, I provide a platform in which the patient can get sober. And then I make them wait 12 months. And we really assess whether or not it's the stimulant or the drug that's causing dysfunction at the front of their brain, the prefrontal cortex. I make them wait 12 months, and I tell them that up front. And if they participate in treatment and they follow through with my treatment recommendations, and they still have residual symptoms suggestive of ADHD, I do a longitudinal history. Most of the time I do that from the very beginning, and I look at their childhood and their development and difficulties that they face growing up prior to substance use, which could also be trauma exposure with this patient group, et cetera, anxiety, depression. Sometimes I'll refer them out for a second opinion. So my countertransference, or the way that I feel about patients, doesn't get disrupted. I rely on my therapy peers, my psychologists, my social workers, and I say, hey, like, what's your opinion of this patient? And then if they are appropriate, if we all feel it's appropriate, we do informed consent. We talk about the risks of relapse. We talk about the risks of dependency, and then I treat the patient. Because I genuinely believe in 1 week, this was 6-8 months ago, in 1 week, I was seeing patients at Crawford County Jail, and I had 2 patients tell me that they were using intravenous methamphetamine at the age of 8, provided to them by their parent, right? So I genuinely believe that there are patients with ADHD who use substances. I do. It makes me uncomfortable, but I'm also not going to withhold treatment from someone who is engaging. And so that's my opinion. I work with some providers that don't feel comfortable treating ADHD with a stimulant, and I respect their opinion, and they're not forced to do any of that. But I hate the idea of untreated ADHD continuing to disrupt someone's life. And there are drugs, guys, that are only activated. You can take a pill form of it, and it's only activated once the metabolism of the drug takes place in their stomach. So I'm not prescribing instant release amphetamine to these patients. I'm putting them on extended release dextroamphetamine, or I'm putting them on Vyvanse or Concerta. That is, the stimulant is only activated once it's in the GI tract. So they inject it, they get no benefit. They don't get any euphoria. There's no rewarding factors. And remember, when we think about addiction, it's the anticipatory reward versus actual reward. Take the reward away. Therapeutic benefit will hopefully outweigh that.
Wonderful. Thank you so much, Eric. And that's actually all the time we have for today. So we want to thank you so much for your presentation, a ton of great information. Thank you so much for being here with us today and sharing your insights.
Yeah, thanks for everybody who attended. Reach out to me with any questions. I'm thankful for the platform.
Wonderful. And if you'd like a copy of Eric's slides, again, you can go to the session page and select files and download the slides there. We're going to take a quick break, and then we'll be back at 1 o'clock for the next round of sessions. So we'll see you back at 1. Thanks, everybody.